one of the things that we do need to start though with all of that is actually, you know, what do children and young people, you know, really think and feel about coming into, you know, like an epilepsy service or a diabetes service or any service that's there to support their health needs. So this is where, as you will have seen from the information that went out this morning, we're going to have an off-camera task. So, you know, if we were sat together in a big conference room, you'd be, you know, like some of you going off to the cafe area, some of you like gathered around a table, some of you, you know, maybe going and doing like a walking chat outside. And, you know, even though we're doing online stuff, we can still recreate some of that as well. So I know that you're not all in the same room, but you should all know how to communicate with each other. So whether that's you can set up your own quick WhatsApp video call, or, you know, you're using Teams, or you can go old school with the phone. Or you want to use, you know, kind of like an instant messaging service that your trust has. What we want you to do in your teams then is to really think about, you know, if children and young people did have a magic wand and they walked into your service, what would they want to see, feel, hear and experience? And this is coming back to that kind of like, you know, person-centered, patient-centered experience measures. So, you know, we use sometimes in the sector that I come from, so youth and community, outcomes-based accountability. So, you know, what would they tell you was the point of that panel meeting they just sat through? Because it might not be the same that everybody else around the table thought was the point of it. You know, so it's really putting yourself firmly into their shoes and thinking through, you know, what might be their experience and what might they be after. So the if you haven't checked your emails, please do check your emails, because that's where the handout is for this part of the session. We want you to create 3 personas. So think of maybe, and there's some examples in the worksheet, think maybe of a child who isn't, you know, isn't able to have friends because they're having too many seizures, so they can't go and enjoy kind of like stayovers or go to parties, that kind of stuff. You know, if they're coming to see you, what might they want to see, feel, hear or experience in their interaction with you? Or it could be a young person who maybe is non-verbal or hasn't got English as their first language. Or it could be, you know, like an 11-year-old that maybe some other things haven't worked for their epilepsy care, and actually now, you know, surgery is being discussed, but it's also at the same time they're moving to secondary school. And, you know, place that in the realms of the pandemic, maybe it's the first time for a while they're going back into class as well in a new school. So, you know, if they're coming into your service, what do you think each of those personas would want to see, feel, hear and experience? So what we're looking for you to do as a team then, and you'll have to designate this yourself, so you're going to have kind of like 20 minutes, is to spend 5 minutes on each persona. It's really quick, don't overthink it, go with the gut feelings, because if you start to overthink it, you professionalize it, you turn it into roles, you know, you think about, we have got that, haven't got that. So what would that child want to see? Draw it on a little outline of a person, because we're going to ask you to take photos and share those pictures into the chat for this stream, so that we can see from each team your pictures coming in, because then we can all learn from each other's views. But what we want you to feed back is, having done that activity and that exercise, what is something that you have kind of like felt through doing that activity? So is there something that's really just made you think like, oh my gosh, okay, now I've thought about those 3 personas in this way, actually this is the thing as a team that stands out? But also, is there, you know, something that's popped up that you're thinking, hold on, for our QI project we need to now start exploring this, or we need to think through this as maybe a test of change, so that we can, you know, so that it's also becoming centralized to your QI. So I'm going to start with Doncaster. So if someone from Doncaster would like to share your 2 reflections, so one on the activity and one on an idea or thought to explore as part of your QI programme coming out of this activity. So Doncaster, over to you.
Hello, hi. I'm talking in behalf of the Doncaster team. We have quite a few team members here. So the thing that we were just looking at, we were basically communicating with each other via WhatsApp, via different rooms. So I think we were just looking at, and we were saying that from reflection point of view, we were just saying this thing, that's a service from children's and young people's services has to be sort of more inclusive and has to be user friendly, which should make them feel more welcome and that they have got a more say in their decision and in their treatment.
Excellent. And did any of those, are any of those things something that you want to now explore as part of your QI project?
I think there are quite a few things actually, but one of the things was that was mentioned by Dr. Habib was that one of the things apart treatment and also like mental health support and transition were the things that was looking at different age, obviously ages, but the more older you are, the college and the transition and the support and mental health support was something that was, and support groups was, was being looked at.
Excellent. So there's something that's come out of your discussions then is clearly about feeling inclusive, but also the differences that might come out of the age ranges and the age and stage, which again, QI wise, is something we're going to have to think about, particularly in refining that engagement approach.
Absolutely.
So thank you very much. Thank you very much, Doncaster. Very much appreciated that you went first there. Epsom.
Hi there. Yeah, we were discussing obviously how the young person felt, and we wanted them to feel safe and that they trust us. So we need to be treating them confidently, have appropriate equipment, appropriate communication tools for them, enable the parent or carer, somebody that knows them, to be with them. It might include the safety, the equipment could be hoists and that sort of thing, and appropriate communication with all ages and disabilities.
Fab. So safe and trust is probably the bit that's come from the children and young people's point of view.
Yes.
Fab. So QI wise, was that already in your thinking for your QI project, or is that something to explore?
Yeah, I think that's something to explore, something that we hadn't really thought of, so it has been highlighted.
Lovely, thank you. Thanks very much as well, Epsom, for responding to the request from the Eurovision jury. Croydon, I've seen a couple of you come back into the meeting, so hoping that you're ready with your reflections.
Hi there, yeah, we are. We spoke about 3 different children. Do you want me to speak about any one of them in particular, or just pick one of them?
None of them in particular, just your overall reflection as to kind of like what stood out from doing it.
Yeah, so what stood out for us was to make sure that the child's voice is being heard, whether that be from a child who maybe doesn't speak English as their first language, or make sure that anything that we are doing is appropriately tailored for the age of that child. So whether that be information leaflets, whether it be just talking to them. Also, we want to make sure that they feel that the people that they see the minute they walk in the door are friendly faces. I know we've all got masks on at the minute, you can't necessarily see the faces, but at least with the eyes, that you're making sure that those children are feeling as though that they've been welcomed into a child-friendly environment. Make sure that you listen to especially the teenagers about their anxieties and their worries, talking about if they've got issues with friends, issues with exams, if it is a new school that they've just started, do they know anybody in the school? What does the school know about that child's epilepsy? What does the school know about maybe any surgery that they've had? And maybe
I'm just going to stop you there, just because we're just doing one overall reflection.
Oh, sorry.
That's all right. That's all right. So, but I think what will have come out, so if you think about it from the child or young person's point of view, that they've been heard on whatever topic they want to tell you about that's of importance to them at the time, but that actually that is received in a friendly way at all parts of the service. So QI wise, thinking about your QI project for your area, have any of those bits come up, or is that something that you're going to think about going forward?
It's definitely something that we're thinking about going forward.
Brilliant. And that's the point of this kind of exercise, is to really put ourselves in their shoes, and then to think about actually reflecting back on our QI ideas. You know, have we captured that, or are we not coming at it from what might make the biggest difference to children, young people and families? Fab, thank you very much. Okay, let's try Salisbury. So Jim, I know you've popped something in which I will try and open, but if you want to just do your one overall reflection about what's kind of stood out, and then what difference that might make for your QI programme.
Thanks. I guess the one overriding thing was that we found it quite tricky, actually, to think what exactly they're wanting from a regular clinic attendance. Given that, of course, these are chronic patients, aren't they? So they're seeing us all on a very regular basis. And at the moment, we're just one team, really, so one consultant and one ESN. So the familiar face bit, the friendly face, hopefully we've just about managed that with and without masks on. I think certainly for the scenario we envisaged, which was, I think, in order for us to try to answer the questions, we found it very difficult to think generically about the children we see in general, and found it much easier to think about specific patients that we've had and relate some of those see, feel, hear issues to them. I guess the top thing for us is familiarity, and familiarity with the process and the place, actually, certainly for some of those children with learning difficulties and other issues that keep them, that make certainly the girl that we put in this scenario, who found it very difficult to stay in clinic for any significant period of time. And we used to we generally just try and do whatever it is that makes her comfortable and respond to her cues. So I guess there's that aspect of it. Key learning to take out of it, actually, for the QI project, I think partly because we're trying to look at improving our first seizure pathway and first seizure clinic, is probably to try and make sure we've got an engagement process with the young people that we're seeing, probably as well as their parents, to try to make sure that any changes, what change we're making, are stuff that they really want to have, that will make a difference to them, as much as just to our epilepsy 12 numbers.
Yes.
So thanks for that.
No, excellent. And I guess just picking through what you just shared, so that bit, that, you know, really recognizing it is hard for us to know what it's like for them without us asking, and without us checking back with them as to, you know, what do they want to see, feel, hear, experience. But familiarity, I think, will come across with quite a few different teams as well. But good to think QI wise about how you're then going to consider the voices of young people within the programme. And like you said, not just what's coming out of the data from E12, because we need to match that against, you know, where they're at within the QI. Thank you very much for that, Salisbury. And just so that we can see that Bart's has shared theirs as well. So feeling understood and listened to, with the opportunity to voice concerns, regardless of age or ability, with the use of appropriate information and toys. So that's what Lynn would have been trying to say to us. And there's a couple more pictures that have been dropped in. I've just copied and pasted Salisbury's picture in off the document, just in case that's easier for other people to see as well. And Bart's have dropped their picture in too. So thank you for that, Bart. Okay, I think we'll just see if Warrington are there.
Hi, I'm Kate Hunter from Warrington. In terms of doing the pictures, we felt that if there really was a magic one, then probably most of our patients would wish their epilepsy away and have nothing to do with us. But I hope that we're quite an empathic team. We've got some really active epilepsy nurses that go into schools and support families in a really positive way. But we sort of looked at how things change for patients. So in terms of they may be coping at one stage of their schooling, but when they get perhaps towards the end of primary school or starting secondary school, then their experience might change, and we need to be responsive to that. Also, we had a patient who went through the surgical process and it was very successful, but actually she said to us afterwards, I miss having seizures. So really quite unexpected responses sometimes from patients. But I do think we do routinely ask about patients, how they're doing emotionally, behavioural and school progress as well. So I hope that we are responsive to those needs, and we are quite a cohesive team in terms of familiar faces and being supportive. In terms of our QI project, we do need to do a patient engagement process. We are choosing a mental health pathway and package of support because that's a massive gap in our team. I think what makes me nervous is that the patients might ask for something that I then can't deliver on. But I definitely want their input, because that could sway how
go on.
How I get the input. But
I was just going to say that really does link back to what you'd kind of said about what might come from them if we were thinking about what they want to, you know, see or feel, is that they might want to feel that they haven't got epilepsy anymore. That is their wish. And I think we need to be really careful in how we leave them space to have that and for us to acknowledge that in any kind of work that we do, because, you know, a lot of the time we're supporting them to manage whatever they've got, and, you know, not unpack the impact that has in their everyday. And particularly, I think some of the things that we've heard from young people, particularly because of the pandemic, in not being able to have some of those conversations face to face, has made a difference to not being able to feel like they can share. You know, I still wish that I didn't have epilepsy. I wish I didn't have to tell my new secondary school that actually this is what I might do, and this is, you know, this is what might happen. So I think, but how we marry that with their expectations, you know, sometimes can be a challenge. Some of the things we do in terms of our engagement, though, is we get them to look at, you know, that broad range of, you know, if we could change everything, if we could change something, and if we could change the smallest little thing. And I think in terms of a mental health pathway, it's quite useful to think of it in that way. Yes, they might say that actually they want a massive change in terms of mental health provision, and that might be aspirational for us. A quick change or an easy to do change might be to have better information and support between meetings, and that could be achieved with some of the national helplines and support services that are already out there, but signposting better. So, you know, sometimes we talk in no cost, low cost, maximum cost. Sometimes we talk in massive aspirational, what can I just do tomorrow that's different and going to help. So that might help manage some of those expectations if we engage with them in that way, so that they start to prioritise what they would like to support. Thank you very much, Warrington. So I think we've got Anglia. You should be with us.
Hi, so we are here together as a team, so we decided to be in the same room.
Excellent.
To be honest, a lot of the things that have been mentioned we echo, which is around trying to meet the needs of a huge variety of patients we see, and around being very welcoming, and it's something that we do try and do anyway, where our epilepsy nurse is front of house inviting, and also to try and meet the needs in terms of what we have in the room available to make it friendly and welcoming. Obviously, like all the previous talks, that if it was a magic wand, but it will be around not having epilepsy, but trying to support them and have the space to have those discussions, which really is something that we're not achieving at the moment. And it's going to be something that is going to be part of our QI, which is quite broad at the moment. We're trying to narrow it down to try and fit it in.
Fab. So, and I think from what you've just said, from what a child or young person might say, is the words that you used were friendly and welcoming, and then space. So either space to see you, space to discuss, space to explore, which definitely feels like that could help maybe in thinking through that refinement of the overall QI. Thank you very much, Anglia. North Tees, I think you're with us.
Yeah. Oh, hello there. Hello there. Yeah. We're all as a group as well, and quite similar to everybody else. We've echoed quite a few of what the other teams have already said, but we felt that, you know, it was trying to accommodate for the different, you know, types of patients we're getting through, the age groups, the level of development, sort of teenagers with transition, things like that, and what they would all like to see. And the overriding things for us were, again, sort of quite, you know, often seeing a familiar face, so they're not having to re-go back through histories all over again, you know, somebody who knows them, somebody who can give them the information that they need. So for things like transition, you know, give them the facts, you know, who's going to take over their care, who's, you know, where would they go in future if they ever have to go to hospital, you know, who's their new consultant going to be, who's going to do their training in school or college, all of those type of things, really, seeing those friendly faces. It's quite daunting hearing the difference between, obviously, paediatric service compared to adult services. They're going to have to take a lot more independence, attending appointments on their own. So just trying to find, you know, a way for them to transition smoothly, to be confident, to be in control of their own epilepsy when they move forward.
And how does those reflections fit what you were thinking for your QI, or what might need to be explored within your QI project?
Well, our overall reflection is that we perhaps may not be putting ourselves consistently in every patient contact, you know, our own patient shoes. We may be identifying mostly with the parents' needs. So we will have to need to broaden our engagement style, and so we reflected that, you know, we our engagement style should be varied, taking into account the developmental needs of the child, you know, their learning disabilities, language barriers, what young people specifically needs, adolescent specific needs, you know, incorporate all that into our QI project. And so we were thinking of...
Right, and the third part is how we're going to do it. And the first thing we're going to do is we're going to do a questionnaire, and maybe not send it to all of our patients because we've got more than 200, but have a selection of each group. For example,
I'm just gonna stop you there, just because of there's 2 more teams to go, and we're not going to go into the detail of what you're going to do just at this point. So hold on to your questionnaire thoughts. But what I've picked out from what you said about you know, the reflections that might come from children and young people then is that it's for them and it's relevant for them, and then they've got a list of questions that might need to be answered. And your QI bit then is about how you create a varied response and process to engagement, and they're the bits to kind of hang on to at this point before you get into the what that might look like. But thank you very much for that one. So we've got Oxford and West Yorkshire. You're the last 2 to join the Eurovision roundup. So Oxford, are you there? And West Yorks, are you there?
We are. Should I go ProNab and then you can add anything in? So we did lose a couple of people, but me and ProNab were there to do our task. That's good enough. But basically, in terms of one overall reflection, is actually just viewing the family as a whole. So what we did, almost 3 age ranges from 3 6-month-old all the way up to the 14-year-old. And the reality is, when you're engaging with those different age ranges, actually the relationship you have with the parent's different. So actually in the beginning, it's more about that reassuring the parent, creating that positive experience for the baby or the child. When you're starting to get into the 6-year-old range, it's actually about how you start developing that relationship with the child, to have that positive health and care journey in the health and care service from the beginning onwards. And then actually when you start getting to the 14-year-old young person age range, it's actually viewing them more as an equal, giving them the space to ask questions, to actually also have space with the consultant themselves. And that gives that opportunity to have a bit of that whole systems approach, to actually use that opportunity to, are there any other issues, etc., that they may face. And I think the one idea thought that we had was around, as part of our EQIP, we're looking at almost a public-facing version of a first year of care. And actually, it's recognising that whatever we put down in a public-facing document about how we have that discussions with children, patients, families, will have to be we'll probably need to be careful about how we phrase it, so it's helpful for the family and it's helpful for a young person as well when they're accessing the service, because otherwise there's just a risk of just doing something that's just designed for parents or something just designed for young people. ProNab, did I get everything, or is there anything that I've missed out?
Yeah, no. First thing was definitely the welcoming and child-friendly environment. That's very important. Obviously, it depends on the age of the child and parents, and obviously giving the importance of the child talking to directly that they feel that they are welcome here, and then you can talk to child first, that why he is here. You need to clarify that. You can ask them, do you know why you're here? And then you talk to him first and then go to parents.
Yeah, excellent. Thank you so much. So, and again, in that one, the bit about going back to the definitions, that relational aspect and how that moves between different parts of the family. and how we do need to take that into account, particularly when we're designing our process for engagement then, because it isn't the same, and lots of you have come up with that. Thank you to all of you for doing that activity. And I think one of the other experiential learning things to think about is how often do we do that to children, young people and families in our appointments, where we say, you know, can you tell me something quite quickly, without much time or thought, or maybe without even having all your support networks around you in the same room to share in that discussion. So just think through when you're doing your engagement, how difficult that might have felt in some ways to understand the instructions, to pull together those thoughts, and then to process that in the 5, 10, 15 minutes that you had, particularly when you're thinking about actually how you then drop engagement into maybe some existing clinic sessions. Megan's just going to do the next slide for me, because I've handed over my Wi-Fi drama to someone else, which is always nice. So just as we move through to kind of like the next kind of like part of this session then, is just to start thinking about some of those engagement foundations. So we've already looked at why this is the right thing to do, and that goes back to that rights-based approach, but also thinking through you know, parts of the NHS constitution and how we need to make sure that we, you know, we have got actually children, young people and families informing and shaping our work, because, you know, that is it's a United Nations Convention Rights of the Child for them, but it's actually also part of what's expected within the NHS. The how it's going to make a difference then really links back to that activity that we've just done about, you know, what would patients say from their point of view that, you know, they're looking for, and that the difference this might make if actually they come in and you've drawn a smiley face on your mask, because you know we're saying that we want to be warm and welcome and friendly. What are some of the things that we've got with stickers that we could do on our masks just to, you know, bring that in from the outset? So, you know, that how it's going to make a difference is really about thinking about that patient-centered, person-centered approach. So to think through some of the things then about what we need to consider to be successful really starts to look at actually that process and the science part behind engagement. And some of it we're going to do now, some of it we're going to go on to in the session in October. So the next slide looks at that what broken down into kind of like 4 different areas. And these are, you know, like, I guess the kind of like starting point of your engagement planning. So it really is thinking about, you know, that approach then. There's a couple of elements for us. So one is about thinking through the expertise that's needed. So not everybody is brilliant at doing engagement work with groups of children, young people or families, or managing those kind of different types of conversations where we're looking at service shaping. So, you know, really do think about in your QI team then, where are different people's skills, and you know, who actually within your team is best placed to talk to the parents, or best placed to talk to the children or the young people, or to hold a group discussion where you've got 3 or 4 young people together. Because actually it's much better that you have the right people deployed in the right way across the team, and that then that supports the engagement to go well. But also think about who else you've got in your trust, because you might have youth workers or people with inpatient experience that can support, or your play workers who can give you some ideas about tools and techniques that they use to have conversations, or your learning disability team, for example, to help give you some symbols and PECs and widgets stuff that can then help for the people that actually might need some visual prompts to understand the questions. So really do think about that expertise level, but also it's really important to think about the power dynamic. So what we find when we go into hospitals, we're able to say, we don't work for the hospital, we're not part of your medical team, so you can tell us what you're thinking that you would like to see differently, or, you know, what your hopes are for the service. It can be really difficult if you're their direct doctor or their direct nurse to be having those conversations, because actually there is a power dynamic there around what's going to happen if I don't give them the right answer. You know, what's going to happen actually if I say that I would prefer they did this or something else? Is my care going to be impacted if I don't do this? And I don't really want to, but I feel like I have to. So we'll also see if you can think about that in terms of how you're going to deliver your engagement to make sure that the approach is made by the right person at the right time in the right way. There's also some safer working practices to take into account with the approach as well. And that's things around, you know, just checking in with your information governance team around collecting data. And, you know, are you okay to collect that kind of information? How are you going to keep it safe? How are you going to make sure actually that you're managing any consent issues around sharing that information? So, for example, if you're bringing them together to do a chat and it's outside of their clinic appointment, you might need to think through, you know, that how you're going to consent for them to come if their parents don't stay. What is the risk assessment that you might need to put into place there? And that safer working practice thing is really to support children and young people's well-being and their safeguarding, but also to make sure as staff that you're supported, particularly if you're doing a piece of work outside of your normal clinical practice. So, you know, do take that into consideration as well. When thinking about the topic, then you need to have a think about, you know, the why. So, you know, what is the driver behind why we're asking these questions? Has it come from us? Has it come from the data? Has it come from trying to explore what that means for children, young people and families? And actually, in asking those questions and bringing them into that engagement in an active way, and this is the thing with engagement, which is slightly different to patient experience, it's really about ramping up that active role. So they are involved in shaping services, not just in sharing their view. They are involved in helping us to formulate ideas and deliver those ideas, not just tell us what they think. So we're making that transition now from patient experience up to kind of like QI engagement. So within the topic, you need to be clear around where their influence is. And, you know, and we just explored that with one of the teams around mental health, how you can then structure those conversations to help them to be able to give you stuff that they can see is useful, meaningful and has influence, without you being caught up in the fact that I can't knock the hospital down and start again as much as I might like to. But, you know, what are some of the things that actually we can achieve together tomorrow? So quick wins or no cost arrangements. But also think about in the topic what's sensitive and might need different support. So, you know, if we are, and I know one of the teams, for example, talking about SUDEP, you know, how are we going to put a therapeutic response around that engagement activity to make sure that we do have the space to unpack what might come up, but also to think about actually if there's siblings involved that had no idea that that was something that could go on for their brother or sister, you know, how are we extending that network of support around some of those questions? The style then we need to think through as well. So what delivery is going to work for them as children, young people and families? And on the whole, we say, you know, don't do a questionnaire, because actually questionnaires for children, young people aren't the way that they would prefer to share their voices and views. It could be a patient experience measure, for example, where we're just asking what they think. But in terms of engagement and QI engagement, we need to be able to creating ways where actually it's a little bit more collaborative and we're sharing the space, but also sharing the power and sharing the thinking. So sometimes we do is, you know, we do verbal questionnaires. So we ask 3 questions and then we get those results. We then get a group of patients together. And sometimes we've done that. I remember doing it in a couple of hospitals where we've just sat in the like outpatients area and gone through the ideas once clinic's over with some patients and families, or we've done it in a ward-based way, where, you know, we start moving those ideas around on post-its and start putting them together to see, you know, what are the same ideas, what are different ideas, what are the things that we want to take forward and explore again. So there's ways to take the questionnaire principle, but to turn it into an engagement process, so it moves out of experience and into that that joint thinking and that practical action to create a positive change together. You also need to think about style-wise, what might be your data needs. So is it important in the style, for example, so if you're doing like verbal questionnaires, or if you're doing a discussion-based activity, that do you need to know who said what? Do you need to know if actually this was a group of children who were 8 years old or a group of children who are 14 years old? Or do we just put children and young people and actually that's fine for what we're doing? Because, you know, under GDPR, we can only ask and we can only capture what we absolutely need. So we don't have on any of our stuff the full long list of ethnicities, because actually at the moment we're not doing anything where we need that difference, and we need to be able to pull apart the results and say that Southeast Asian families told us this, Eastern European families told us that. If you need that, then you're going to have to build that in, but you really do need to think through in that style what's going to work for children and young people to be able to share their voices, views and their ideas, because it's more than just their voice. But also, you know, what kind of data points are you going to have to report on? And again, in that style thing, and we're going to go into some different styles in the next session, don't worry. We're going to explain some kind of like actual practical tools and techniques to do this. You know, how do we then within that manage that power and influence question? So, you know, is the style the right style if their doctor is asking the questions? It might be. Or is the style a better style if a different member of the team pulls them together and asks to chat, you know, asks to talk to them, so they can see the difference between their individual care and person-centred care, for example, and QI and affecting change for a service. So you might need to think through style-wise how that's done. And again, for us, lots of our work actually is group work. So children and young people always tell us they want to meet other people with epilepsy. We just had some of that feedback for something that we did a couple of weeks ago. You know, it was really nice to meet other people, to talk to them about their experiences, to do this together and it not be about my medicines, but to be about, you know, other people with the condition. So think about maybe how you could form some group work around one of the style points. But remember, it is their right to be able to have this voice of view, but it's also their right within the style to have information in the way that works for them. So as some of you have mentioned around being inclusive, you know, that might be where you need to get some support from your learning disability team to see actually if there's any other ways to, you know, to take what you're hoping to ask and to turn it into a game or activity or a worksheet that works for children and people with different needs. So actually it does meet, you know, their right to have information in a way that they can work with. And then on the access point, there's a couple of different things to consider. How are you going to manage gatekeepers? So one of the things that we're always asked is, how do you manage the parents? If you're trying to find out stuff from children and people, how do you manage the parents in that process? So I'm doing clinic chats at the moment on diabetes care. We've got a really simple visual tool that we use, which is a piece of paper with a line down the middle, and one side says child or young person and one side says parent, so that when we're doing our verbal questionnaires and we're talking them through and, you know, saying, like I was doing yesterday, you know, how would you explain type 2 diabetes to other children and young people that might find out for the first time they've got it? If the parent's talking, it goes on the parent's side. If the young person hasn't said anything, then I can be like, okay, your side, we need to get some stuff on your side of the paper. You know, this side's nearly full. So, you know, think about your visual cues as to how you can manage some of that. Or also what we do is we have extra workers. So, you know, if there's 2 or 3 of you in your team, have one of you geared up to talk to the parent and one of you geared up to talk to the child or young person, so that actually they can both have their space and have their needs met as to how they want to engage and how they want to help the service that's helped them so much. But you do need to think that through, because gatekeepers are a real challenge with engagement. And I think that's why often lots of things are geared and reflective of what the parent or carer needs or wants, rather than creating the appropriate processes for children and young people within that. And then, you know, as you will already be doing in many of your conversations, how you manage the age and stage appropriateness. So, you know, really understanding, you know, what might be the best way for a 5-year-old to communicate might be the same best way for a 15-year-old. You know, being really clear on the assumptions that actually not all young people suddenly want to text you everything. Some of them that we've found would still like to rip pictures out of magazines and use that to build a trigger board or a mood board about how they're feeling, just like smaller children would do. So, you know, really think through some of the different options. And I guess what we do as a team, whenever we go into any engagement approach or process, we've got 2 or 3 ways in the back of our head as to how we might get the same, you know, kind of like answers or discussions going on, because they don't always work when you're in front of them. And actually, you know, if you've got 2 or 3, you might need to use all 3 of your different options to support them. So in the next couple of weeks, you'll be starting to think through, you know, what your QI project is, how children, young people and family involvement will support that QI engagement. So again, like I said, making sure it's really active, really making sure it's 2-way, really making sure that you're thinking through some of the ways to make sure that they have got genuine influence and they can come and go within the process, you know, as they see fit. But we'll be looking at some more practical tools and some inclusion elements at the next session. But the next slide is just a nice little reminder about some of the support that's already there for you. So, you know, there are loads of resources on our website already that have been created by children, young people and families with us, or by the staff, to help some of the engagement. We've got the engagement collaborative newsletter, so the next one will go out at the end of September, which has got other like examples and resources and things to kind of remind you. But I guess just just start thinking with your progress calls and your catch-ups that will be happening in the meantime, some of the questions that you might not like us to include into the October session, because we're here just as much to give you things that we think you might need, but also to react to some of your requests. And Pat is just going to let you know some of the next steps and then embed this back into the QI process. So over to you, Pat.
So first of all, I just want to say thanks, Emma. That was an absolutely fantastic afternoon, and great ideas from the teams. What we need to do now is really develop your definition of engagement for your team so that it's relevant in your context, because obviously everybody works in very different places, and often even if you do work in multiple settings, one setting and the way families and patients engage needs to be very different from another. So really think about that. Context is always everything. It doesn't matter what you want to change. It's about the people that are in and around that process. Also have to think about what matters to me activities, and does that align with your project and your plan? It's always easier when you're trying to change something that you're doing part of the day job, that you're not just thinking up this project to be part of the EQIP programme, but it's something you were going to do anyway. And then you've just got another host of tools and techniques at your fingertips to actually use. And we've covered quite a lot of them this afternoon. It was just fantastic. And what further involvement steps do you need to take to understand what matters to your patients and families? What do they really want and need? And how can you adapt your service and processes to do that? Consider in your team and add your reflections to your progress report for your call later this month. So just want to say thank you to everybody. I know every moment of your day at the moment with all the pressures on services is very precious. So it really was wonderful to come together this afternoon, and thank you so much on behalf of all the faculty and the team, and particularly Emma and the folks that Emma liaises with to produce this session this afternoon. It really has been fantastic.